Cardiopulmonary bypass is a technique that temporarily takes over the function of the heart and lungs during surgery, maintaining the circulation of blood and the oxygen content of patient's body. Often referred to as the heart-lung machine, it creates a still, bloodless field for surgeon to operate on the heart. The cardiopulmonary bypass machine functions as an extracorporeal circuit. Blood is diverted away from the heart and pumped through a series of components before being returned to the arterial system. Venous cannulation. Blood is drained by gravity or vacuum from the right atrium or vena cava. The reservoir acts as a holding tank for the blood and allows air bubbles to escape. The oxygenator or the lungs. This is where gas exchange occurs. Oxygen is added to the blood and carbon dioxide is removed. Heat exchanger. Integrated into the oxygenator, it controls the patient's body temperature, often inducing hypothermia to reduce systemic oxygen demand. The pump, the heart. Usually a roller pump or centrifugal pump that provides the force to propel blood back into the body. Arterial filter, a final safety mechanism to catch any microemboli or debris before the blood enters the aorta. Managing a patient on cardiopulmonary bypass requires a delicate balance of several factors. Anticoagulation. Heparin is administered to prevent blood from clotting within the plastic tubing and components. The activated clotting time is monitored to ensure therapeutic levels, usually more than 400 to 480 seconds. Cardioplegia. A potassium-rich solution is infused into the coronary arteries to intentionally stop the heart asystole, protecting the myocardium during the cross-clamp period. Hemodilution. The circuit is often primed with crystalloid fluids, which reduces blood viscosity and improves microcirculation during hypothermia, though it lowers the hematocrit. While life-saving, CPB triggers a systemic inflammatory response syndrome because the blood is exposed to non-physiological surfaces. Coagulopathy. Destruction of platelets and consumption of clotting factors. Neurological deficits, often called pump head or post-perfusion syndrome, ranging from mild cognitive impairment to stroke. Renal dysfunction, potential for acute kidney injury due to non-pulsatile flow and inflammatory mediators. Transitioning a patient off cardiopulmonary bypass is one of the most critical phases of cardiac surgery. It is a controlled handover where the heart and lungs must resume full physiological responsibility after being dormant. The preconditioning checklist. Before the cross clamp is removed and the pump is slowed, the team must ensure the following parameters are met. Rewarming. The patient's core temperature is typically brought back to approximately 36.5 degrees to 37.0 degrees centigrade. Metabolic balance. Electrolytes, especially potassium and calcium, and acid-base status must be normalized. De-airing. The surgeon must meticulously remove any air from the heart chambers and aorta to prevent systemic or coronary emboli. Rhythm restoration. If the heart doesn't spontaneously restart in a stable sinus rhythm, internal cardioversion is performed. Hemodynamic transition. The perfusionist slowly weans the patient by reducing the venous return to the machine, allowing the heart to fill and start pumping blood into the systemic circulation. Preload management. As the pump flow decreases, the volume in the heart increases. The anesthesiologist monitors the central venous pressure or pulmonary artery occlusion pressure, that is equivalent to pulmonary capillary wedge pressure and left atrial pressure, to ensure the heart isn't over-distended or running dry. Contractility support. Many patients require inotropic support like dobutamine, milrinone or epinephrine to help the stunned myocardium overcome the systemic vascular resistance. Afterload control. If the systemic vascular resistance is too high, the heart may struggle to eject blood, requiring vasodilators. Once the heart is maintaining adequate mean arterial pressure and cardiac output with minimal pump support, the venous and arterial lines are clamped. This is the moment of truth where the heart is fully solo. Once the surgical team is confident the patient is stable off pump, protamine sulfate is administered. Protamine neutralizes heparin to restore normal clotting. This is a high-risk moment for protamine reactions, which can cause severe pulmonary hypertension and requires close observation of the right heart pressures. Common post-bypass challenges. Vasoplegia, a stage of low systemic vascular resistance caused by the inflammatory response to the bypass machine, often requiring vasopressors like norepinephrine. Right ventricular failure. The right ventricle is particularly sensitive to the changes in pulmonary pressures and volume shifts during weaning. During the rewarming and weaning phases of cardiopulmonary bypass, the myocardium is transitioning from a state of controlled asystole and hypothermia back to achieve electrical and mechanical function. This period is highly arrhythmogenic due to electrolyte shifts, catecholamine surges, and reperfusion injury. As the heart temperature rises, electrical activity returns, often in a predictable but chaotic sequence. Fine ventricular fibrillation. This is common as the cross clamp is removed and oxygenated blood hits the cold potassium-laden myocardium. If it doesn't spontaneously convert to a perfusing rhythm as the heart warms, internal defibrillation, typically 10 to 20 joules, is used. Junctional tachycardia, frequently seen in the warm-up phase. The AV node may recover faster than the SA node, leading to an accelerated junctional rhythm that can compromise cardiac output due to loss of atrial kick. Post-bypass arrhythmias and ECG challenges. Atrial fibrillation, that is post-operative AF, is the most common arrhythmia occurring in 25 to 40% of patients. Mechanism: it is driven by systemic inflammation, oxidative stress, and changes in atrial pressure. While often transient, it can lead to hemodynamic instability in a freshly weaned heart that is preload dependent. For patients with underlying ischemia or previous scars, reperfusion can trigger ventricular tachycardia. If the patient develops PVCs or VT post-weaning, clinicians look for specific morphology. For example, left bundle branch block pattern with an inferior axis often suggests an origin in the right ventricular outflow tract, which might be triggered by surgical manipulation or cannulation sites. The proximity of surgical sutures to the conduction system, especially in valve replacements, can lead to complete heart block, often requiring temporary epicardial pacing wires which are standardly placed before chest closure. Right bundle branch block is very common after right ventriculotomy or even simple right ventricular distension during the bypass. The so-called shark fin and ischemic patterns. In the immediate post-bypass setting, a shark fin appearance, that is massive ST elevation, is usually a red flag for acute graft occlusion or coronary air embolus. Unlike Brugada pattern, this is an evolving injury pattern that requires immediate surgical or interventional attention. Epicardial pacing is used to maintain an optimal heart rate, usually 80 to 90 beats per minute, to optimize cardiac output while the heart is stunned. Keeping serum potassium more than 4.5 milliequivalents per liter and magnesium more than 2 milligrams per deciliter is the first line of defense against both atrial and ventricular irritability.